Good evening, everyone, and thank you for joining us for the OTEP Clinical Case webinar. My name is Jale Gholami, and it's my pleasure to be hosting tonight's session. Tonight's topic is urine drug screening and the management of results, a highly important and often challenging topic in opiate agonist treatment. I'm honored to introduce our speakers, Dr. Richard Hallinan, addiction medicine specialist from Hunter, New England Local Health District, and Dr. Daniel Dutkiewicz, addiction medicine advanced trainee from South Western Sydney LHD. Before we get started, I'd like to acknowledge the traditional custodians of the land on which we meet today and pay my respects to their elders past, present, and emerging. I also extend my respect to any Aboriginal and Torres Strait Islander people joining us today. Here is a quick overview of where we are joining from this evening. This is based on the list of registrations for tonight, not actual attendance. It's encouraging to see participation from a range of LHDs, including strong representation from metropolitan areas and a solid mix of attendees from regional and rural LHDs. We have approximately 54% from metropolitan areas and 38% from regional areas. We have also a wide range of specialties and roles represented among tonight's registrants, reflecting a diverse level of interest in this webinar, which is very exciting. Welcome again to everyone who has joined tonight. This is the 6th webinar of 2025. As you may know, OTEP clinical case webinars are held monthly on Tuesday nights. All webinars are recorded and the recordings are available on the OTAC website. An e-certificate will be provided to attendees, which you can use to self-claim your CPD points. To ensure a smooth session, please keep yourself on mute during the presentation. You can submit your comments and questions using the chat box, and we will aim to answer them at the end of the presentation. We will also have a few Zoom polls during the webinar. Your participation is encouraged. Just a quick reminder that this webinar is being recorded, so please avoid sharing any confidential or identifying information during the session. Now I hand over to you, Richard.
Okay. I won't say much about myself, staff specialist. I'm still working currently at Hunter, New England after a long stint in Sydney. And I've got about 25 years experience doing OTP, though I don't do a lot of it now. OTP or OAT or MAT, whatever you'd like to call it. Those are the objectives which you can read. I won't read them out. I'd just like to stress that we need to be very aware that urine drug screening can have a downside as well as an upside, and it can affect the therapeutic relationship. It's really important for us to understand urine tests very well, interpret them correctly, be aware of the pitfalls that can happen, because I think we've all seen some disasters over the years where urine tests have been misinterpreted or misused. I want to start with the acknowledgement of Peter Bowron, who presented our Sydney Addiction Seminar all of 13 years ago on a very similar topic. He was a senior hospital scientist for Palms Laboratory for a long time, and a really great expert, as was John Lewis. And if you see the initials PB on the slides that follow, that's reference to Peter's seminar at that time. Now, a few things have changed, but much remains the same. And at that seminar, Peter started with the question, why test at all? And he cited a study where people who were professionals in recognising the effects of substance use were asked to decide from direct observation whether people had used any of those 4 classes of drugs, and if so, if they thought they were affected, which one? And their answers were only correct in 50% of cases for any substance use, and only a third of the time could they pick the drug correctly. So Peter said, don't trust yourselves and perhaps don't trust everything our patients say. Specifically, a 2014 national guideline from Gowing and colleagues you see there suggest 3 particular benefits that urine drug screen may enhance the validity of self-report. It may identify substances not reported by the patient that may be important for us to know about, and they may specifically assist determining eligibility for takeaway or unsupervised dosing. An opinion piece recently published, and it's think we circulated it as pre-reading, and you can find it on the internet very easily. It's for free. By Fitzgerald and colleagues, a very, very thoughtful perspective on urine drug screening. And they point out that many people receiving our treatments experience urine drug screening as paternalistic and stigmatising. We should particularly avoid terminology like clean or dirty. A moment's reflection will tell you how the associations with that are really most inappropriate. So a term like clear, for instance, rather than clean is a simple way of not using stigmatising language. There is, however, no evidence of any benefit for the health outcomes of using urine drug screens for people receiving opioid agonist treatment. Meta-analysis has shown that when there are no negative consequences from telling the truth, then people volunteer information that better matches what their urine test shows. They mentioned that the guidelines around all of this, that 2014 guideline, really needs updating because they don't give us very much specific guidance, particularly in the changing circumstances of different types of treatment, like depo-buprenorphine, for instance, but how we should use urine tests. And that's reflected in the great variety of practices in different jurisdictions, and even in similar jurisdictions between and among different clinicians. So here's a poll question for the audience. In your opioid agonist treatment service, whatever it is, which urine tests are used? You've got 20 seconds just to make a choice there. It's not a terribly serious question. It's just to stimulate conversation. Feel free to confess if you don't know the difference between these tests at all. And Charlie will be able to read back the results for us very shortly. I think we've got 5 seconds to go. 4, 3, 2, 1. Am I right? Okay. Daniel, would you like to comment on those?
Yeah, as you know, well, I work at Liverpool OTEP. We do only immunoassay currently. There was a GCMS reflexively done in the past, but it has changed as time has gone by. But we don't get the full benefits on what the private laboratories give in terms of the other extra results, which I think you're going to talk about as well today.
Okay. I find it interesting that only a minority of people don't do any urine tests at all. I find that pleasing because I find it a bit difficult to imagine how you could do these treatments without urine tests. So now, let's start with immunoassays. They're the simplest kind of test. They're cheap. And they're based on competitive binding. And the example given there is if cocaine is present in a sample, essentially it will compete for something that would neutralize a colouring process. And so by competing for that, it will cause a colour change, which is what is read. The technology is really quite simple. They're generally quite sensitive for whatever drug they're looking at. The problem is with the specificity. If they're too specific, in a way they may miss important drugs. So some examples are there. If you really want to know about all opioids, but you're using an opiate immunoassay, it will miss important drugs like fentanyl and oxycodone, absolutely. And similarly, some benzodiazepines don't come up on a benzodiazepine immunoassay. The other problem is that they can be too non-specific. And so for opioids, it'll pick up poppy seeds and such things, and codeine use, not just the opioids that you might be after. And similarly, amphetamine-type stimulants, or also known as sympathomimetic amines, that stimulant test is a real catch-all, and it'll catch such things as pseudoephedrine and lots of other things. Some tests like cannabis and cocaine are really very specific and very sensitive, and they're excellent in that way. If we just consider what Peter Barron had to say, if you're only doing an immunoassay, you're not really doing drug testing. Now, I know some of our colleagues who do rely on point-of-care testing and immunoassays might disagree with that. He mentioned what a creature that's now extinct, thin-layer chromatography, which is so cheap and so comprehensive and broad. It was absolutely wonderful. And they used it at Palms in those days. Just imagine a kind of blotting paper that went out, and you just put the urine sample on the side of the blotting paper, and the chemicals soaked across the blotting paper and stopped at different places and in different patterns depending on their molecular structure. And an experienced eye could simply look at those patterns and read them out, all at a glance, at a snapshot. Sounds wonderful, doesn't it? But it needed considerable skill. The current gold standard of testing is gas chromatography, mass spectrometry, difficult word to say, the latter, and it's reliable and very accurate. Peter mentioned two other cardinal rules. A quantitative level under a cutoff is negative and should not be reported. It should be ignored entirely. Now, I'm going to add some caveats to that later based on recent experience where reports are being made under standard cutoffs and the justification for that, but the perils of doing it. He also stressed that if you're doing quantitative drug levels, they should always be normalized for creatinine concentration in the urine. So there were some basics. Gas chromatography is this two-step process, which you can see described there. It's too hard for me, but again, it requires quite expert people to interpret the results. They're searched against a library, and if it's a substance that's not in the library, then it may be unidentifiable. That may be relevant to Daniel and to your case later. The result is reliable and accurate and quantitative. My personal experience is I've worked in a number of settings, and briefly, as Daniel alluded to, in South West Sydney, we had only immunoassay, and I would never want to rely only on that. I've only ever worked in places that had follow-up testing and initial screening tests. Just to mention that in private practice, as opposed to public OTP services, if a person is receiving opioid-assisted treatment under the OTP, you're allowed to order up to 22 urine drug screens under Medicare, and they would follow whatever the process is of that laboratory, which is typically an immunoassay to start with and certain follow-up testing. That's what Douglas Hanley Moyer and Laverty and a whole lot of others do. Personally, I prefer to know if my patient is using other drugs like the ones mentioned there. It can be incredibly helpful. So it's a luxury if you have more comprehensive testing, as we had for a long time at Liverpool. Okay, next poll question. How often should urine tests be requested, and how? There's no correct answer. Please, in the next 20 seconds, just pick an answer, one answer that reflects your views. Option 1 is a kind of sliding scale of frequency. Never is an option. Only by arrangement, only where there's an indication. I would say, if it helps at this point, all of these things I have seen. And these are the poll results. Interesting, 56% of people choosing the sliding scale, which was that used literally by Andrew Byrne at the Byrne surgery for the 34 years or whatever it was where he worked in that business. I'm sorry I missed the rest of them. Let me comment on, again, I seem to be blocked. Right, I'll go back. Yes, burn surgery was number one. Never for a time, and for quite a long time, I think the Langton Centre did no urine tests on the very strict basis that there was no evidence that they did any good. Whenever there was a medical review, was the standard at Drug Health Services in South West Sydney when I was there. I think, though, that we changed that for some people because some people really didn't need that and they found it quite offensive, particularly if they came from the world of prescription opioid dependence, and they weren't generally illicit drug users, and they didn't really want to be shoved through the usual process. Okay, let's move on to the first case which Daniel is going to present.
Before the case, Richard, could I just ask a quick question about UDS that's in the chat?
Yes.
So Brian asks, so when we order a UDS, is that a spectrometry? I have in the past been asked to request it specifically.
Yes, if that's our Brian from Liverpool, howdy, and if any other Brian, howdy as well. At Liverpool, for example, in order to save the costs and make things more efficient, a standard screen was an immunoassay only, and to be followed up if any things like opiates or sympathomimetic amines were positive. They would go on to the GCMS. It's a lot easier just to say that. We could also, however, tick a box that said, please do broad screen. And so that was if you wanted to look for the person you thought was using Lyrica or using Seroquel. And the private pathology labs basically do the first that I described, and they would not generally offer a full or broad screen. And I think in Hunter, New England, if we want that, we really have to specifically ask for it. So we write on the form, please perform full GCMS.
Wendy notes in the chat, we've currently had to change service providers as there is no mass spectrometry provided and patients have been billed.
Well, okay. Shall we press on? Okay, over to Daniel.
All right, thank you, Richard. Yeah, my name's Daniel. I'm one of the advanced trainees currently working at Liverpool Hospital this year, and I'll be presenting some case studies to go along this presentation, starting with this one. So we've got Mr. H. He's a 36-year-old gentleman. You've known him for a while. He's prescribed 120 milligrams of methadone, quite stable for several years now. He doses at a local pharmacy. You see him every 3 months on average. Previously 5 takeaways per week. You've increased to 6 due to his unique work requirements, which require him to travel around the state. He lives with his partner. They've got their own place. She's also on methadone. He only takes mirtazapine. He has no other significant medical history. For your last review, his UDS came back, as you can see, bottom right. When you last spoke to him, he's been abstinent from every illicit substance you could list. He doesn't drink any alcohol, and that's been the case for several years now. So we've gone to the next slide. I'd like to ask, how would you respond to this UDS result? If we... Oh, okay. Also give that about 20 seconds as well. All right. Could possibly move to the next slide as well. So most of you put the first option, basically next planned review. Some no changes, he's on methadone, and some not so sure, which is fair enough. Would it be possible to move next slide? Thank you. And then next slide again. All right, so we're talking about an opiate enzyme immunoassay here. So the typical opiate immunoassay is designed with an antibody against the morphine structure. An opiate is a chemical with something similar to morphine itself. An opioid is different. Opioid is any chemical that acts on the opioid receptor. So if you have an immunoassay or an antibody targeting the morphine structure, you're going to have a lot of false negatives and positives as well for different opioids. So the more synthetic you get, the less likely you're going to pick it up, essentially. So semi-synthetic opioids, endone, for example, moving on to the synthetic opioids, fentanyl, buprenorphine, and even morphine, they're most likely going to be negative on your immunoassay for opiates. However, heroin, being diacetyl morphine, then metabolizing to 6-MAM, and then subsequently morphine itself and codeine, likely to be positive. So you'll pick them up on the immunoassay. For that reason, when you do request a UDS, it's often good just to mention if the client is on buprenorphine or methadone, because then pathology lab knows to further test for buprenorphine or methadone or the metabolites of those as well. If you don't mention that, they're not going to test for it and it will be negative, essentially. Quick note at the bottom, some antibiotics do produce false positives as well. And there was several cases of people eating pastries with poppy seeds involved and also producing positive results as well. Next slide, please. So in this case, it's quite simple. The answer was our patient was being prescribed Panadine Forte with another prescriber, verified with safe script. Having said that, it's always good to review why they were being Panadine Forte. What was the source of the pain? Is it something that perhaps we can address as well? And was the other prescriber aware that you were prescribing 120 milligrams of methadone as well? So nothing urgent, but something to be aware of in terms of positive results for the opiate immunoassay. Thank you. I think we're back to Richard now.
Here's the next question. A urine immunoassay test without confirmatory testing for amphetamine-type stimulants, also known as sympathomimetic amines, or for opioids, is only useful if it's positive, only useful if it's negative, or completely useless, and you have 20 seconds, of which 6 or 7 have gone. A good spread of answers. My answer was the same as the majority. It's only useful if it's negative. If it's positive and you don't do any other testing, it's really not going to help you very much at all. So a positive opiate assay could be anything from poppy seeds, as we said, to full-on heroin. Yeah, but I don't think it's completely useless, just my opinion. So if it's all right with everybody, let's move on to the next slide, which is an example of an immunoassay, which is useful. So in this case, a person who's on methadone treatment the immunoassay has showed the metabolite of methadone, so we know they haven't just dropped a bit of methadone into somebody else's urine or into some water. It's actually gone through their kidneys. The opiate assay is negative, so we know they haven't used heroin within a detection period. Same thing for all of the amphetamine-type substances, which includes a whole raft, which you'll see on later slides. It's positive for benzodiazepines, which has got some limitations because that could have been 2 weeks ago, and it could have been any one of a great number of benzodiazepines. But it's a useful discussion point, and it's picked up cocaine, which is very, very specific and very sensitive. And so I think that's a good example of a very useful enzyme immunoassay, and there was no need to go any further. The next example is also a test that was well done. The opiate immunoassay was positive, and so they went on to test for codeine and morphine and monoacetyl morphine. Just to remind you that diacetyl morphine is heroin, and that's like my favorite Martian. The morphine molecule has 2 little acetyl groups up there. Very quickly after the heroin enters the bloodstream, one of them is cleaved off, and that leaves monoacetyl morphine. And within a fairly short period of time, 24 hours at the most, the other is cleaved off. Negative for all of those, meaning that this was a false alarm and nothing to be worried about. Useful test. What's wrong with this report? Daniel, Sharon, I know you've seen the slides, but maybe you won't remember the answer, and I could ask you just to comment. It's positive for methadone and a morphine trace, which may not be a heroin metabolite. This is from a laboratory that unfortunately was going through a period of decline, and we had to sever our services with them. Any comment?
Is it because we don't know if it's a heroin metabolite? It could be.
Here's the answer from Peter Barron. A cardinal rule is you don't report a morphine trace. It's either above or below the standard, and that's in Australia called the ANZ 4308 standard for laboratory testing for this kind of thing. And your lab's accreditation could be imperiled if they made a report like that. Morphine trace, what does it mean? The speculation that it may or may not be a heroin metabolite is unnecessary. Also, there's no mention of the metabolite of methadone. So saying methadone's there without commenting on the metabolite is a bit problematic. Next question, do all pathology labs in Australia operate in accordance with the Australian standard, New Zealand standard 4308? And I discovered, to my shock some years ago, the answer is no. So hospital laboratories don't necessarily do that. Private laboratories have to be accredited by NATA, which stands for the National Association of Testing Authorities, I think, of which Peter Barron himself was an accreditor, so he really knew this stuff. But when we started getting from Liverpool Hospital, from their pathology service, reports of trace morphine, and I phoned up and said, what's, you shouldn't be doing this. And they said, well, actually, we are not accredited. We're by NATA, we're accredited by a totally different process. And we feel that if there's morphine there and we can see it, whether or not it's above or below a threshold in these standards, the clinician deserves to know it. So it was an interesting question, and it just reminds us that the purpose of those standards properly is to do with legal situations and employment situations, so drug testing in workplaces, drug testing for police and for courts and the like, and DCJ, but not necessarily for clinicians in hospitals. Let's go on to the next one. This urine test came back, codeine not detected, morphine at that concentration, creatinine concentration, a ratio of morphine to creatinine. This lady denies heroin use, but she says that she had Nurofen Plus a couple of days before. Is that a possible explanation? Daniel, what do you reckon?
Yeah, so the morphine creatinine ratio is determining if someone's used something that has more codeine that turns into morphine, or you've got the ratio from heroin, therefore the difference between the morphine and codeine from that pathway as well.
Well,
I can't remember if it's high or low for heroin.
It's a good question, and the answer is that the whole thing is crazy, because again, the morphine is below the cutoff of 300 and should not be reported at all. And therefore, reporting the creatinine ratio is already out of bounds. What's happened here is a sub-threshold report was made of morphine, but codeine was, for whatever reason, not even detected. The meaning of it is purely speculative. It's below the threshold. It's not significant.
Just
Daniel.
Just while we're pausing for a second, there's a question in the chat.
Yep.
And it might be covered later, so let us know if it is. Brian's asking about patients using fake urine. I've heard of users, you often obtain other people's urine or buy urines that are clean, or is it another liquid?
Well, we will to some extent cover that later, yes, but that's definitely a problem. And harking back to Daniel's slide, where if you want your urine test to be tested for buprenorphine or methadone as the therapeutic medication, as a test, it's a lousy test of treatment adherence and should not be interpreted as a test of treatment adherence for various reasons. What it's good for, though, is to confirm that this is likely to be that person's urine. So if somebody's got a substituted urine and it doesn't have morphine, methadone, for instance, if the person's on the treatment, and specifically if it doesn't have the metabolite of morphine, if it only has a little bit of methadone in it, that could easily be somebody's dipped their finger in their takeaway and then dipped it in the urine. So yes, substitution is a potential problem. You have to use your detective skills a little bit. Shall we move on?
Yep, thank you.
Okay, back to Daniel.
All right, case 2. All right, so Mr. L, he's a 43-year-old gentleman who's attending a clinic. He's getting Ritalin prescriptions, which might be a topical issue, given that certain GPs in New South Wales can diagnose and prescribe for ADHD now. He's currently on immediate release Ritalin, and he has been formally diagnosed with ADHD as well. He does have a past history of methamphetamine and cocaine use, but no other significant medical or mental health history and no other medications. We've got 3 UDSs here, which are about a month apart, the left being the most recent. And if you just move on to the next slide when you're ready. I'd just like to ask, what can we determine from this pattern of UDSs? So has he recently used methamphetamine and cocaine? Has he recently used cocaine and he's taking Ritalin, or all 3, or not sure, and where's the GCMS? And I might just give a couple of seconds when the poll comes up. All right, so the majority think all 3. Let's have a look. And also, a lot of you want a GCMS, which I think is fair enough. Next slide, please.
I must confess to having chosen 2 myself, although a GCMS is always good. The reason being that he clearly has used cocaine. There's no question about that.
That's right. I'll talk about amphetamine immunoassays first. So the amphetamine assays, as Dr. Hallinan alluded to earlier, it's designed to detect a lot of things. Amphetamines, similar compounds such as methamphetamine, anything related, MDMA. It will pick up other stimulants such as over-the-counter decongestants as well. It will take up other stimulants for ADHD, for narcolepsy. It will take some psychotropic medications as well. And it will also take some unique agents, labetalol and ranitidine, interestingly enough, as well, will cause false positives. And I've got a long list on the right there, but definitely not a limited list of all the things that could cause a false positive result for the amphetamine immunoassay. One thing I will mention as well is Vicks inhaler. It's more of the older immunoassays have responded positive for an isomer of methamphetamine, but it has shown false positives as well. So it just shows you even over-the-counter medications could potentially give a positive result as well. Next slide, please. Quick word on cocaine, which I think Dr. Hallinan's already answered. It's quite specific. It just particularly detects the main metabolite for cocaine. It's really rare for it to react or cross-react with any other substances. So a positive cocaine response is pretty specific for cocaine itself. There were some reports of false positives from people drinking tea made with the coca plant leaves, but otherwise it's typically cocaine most of the time. Next slide, please. So just a time story for this patient. So he was prescribed Ritalin privately for ADHD. His story was that he would take a lot of tablets of Ritalin over a weekend. He'd run out very quickly, and then he'd just maintain himself with a combination of methamphetamine and or cocaine till the end of the month, and then his script be renewed and he'd do the process again. His dose and the type of Ritalin was changed later on, and so there has been less use of methamphetamine and cocaine since, but he is an ongoing case with us in drug health as well. I've just added the GCMS's results as well there, so you can actually kind of see the pattern of use a bit more specifically, showing you methamphetamine, a bit of a pseudoephedrine use as well, methylphenidate being Ritalin, and the cocaine we've already known about as well. So you can kind of see how it's changed over the months whilst he's been on the treatment. Next slide, please. And I think that's back to Richard again.
And just before I do that, I might draw people's attention to the amphetamine type substances title there for that test. So it's not a test for amphetamines, it's a test for amphetamine type substances, which is, so in fact, if it's positive, they're not really false positives because it's meant to catch all of those things. It would be a false positive if you were using it as a test for amphetamine. I believe at Liverpool Hospital at one point, they left that column blank if it was positive and wrote requires further testing. And in the end, or it was, the requires further testing has also been seen in some private labs. The reason being that a test like that, if a cowboy gets hold of it, can be interpreted and used to do great mischief. And our colleagues, some of them in DCJ, are rather famous for making such exercises in overreach, shall we say. All right, now here's another case where the drugs detected were methadone, and it says no level of EDDP, that's the metabolite of methadone, nothing there. A trace of morphine and 6 monoacetyl morphine, and the creatinine was less than 0.44. Anybody care to interpret?
I suspect this is the fake urine you were talking about earlier on.
Okay, and here the comments. The report itself points out that methadone with no metabolites is suspicious, that the urine is not consistent with human urine, perhaps for that reason, but also because it's too dilute. It's very unusual to get monoacetyl morphine in urine without having morphine there. In fact, it's very hard to imagine how that could even happen. So conservative saying adulteration, substitution, or something else is going is correct. Well, let's look at how low creatinines can go. As Peter Barron pointed out, a first void urine might have 5 times higher concentration of creatinine. He gave us limits, and forgive me, the units used here get quite confusing because sometimes it's micromoles per deciliter and so on, and the decimal points move all over the place, but I hope I've got this right. Anyway, it's consistent with the previous slide, 0.44 millimoles being low. In fact, that's right. It's getting pretty close to the borderline, but Peter called it unphysiological. But it's not that far below 0.5. By the way, in living human beings, you can get a creatinine in urine that's lower than that, but usually the person is dying. They're on the way out. And as Peter said, quantitative urine drug screen should always normalize for creatinine. Now, how useful are quantitative urine drug screens? This is the busiest, most complex slide I've got. Up the top, you see the immunoassays resulting in, from a positive opiate, resulting in further testing, which shows codeine, morphine, and monoacetyl morphine, and some quantitation there, but it's only semi-quantitative. Then they, below that, produce some ratios of codeine to morphine, as if that might help you, or their relative ratios to creatinine. So according to this, there's a higher concentration for the creatinine of morphine than of codeine. But how can you interpret that? Peter Barron was really very scathing when this one came up and said, you absolutely cannot come up with a ratio of any kind from a semi-quantitative assay. Divide greater than something by a number and it's not even a number. So that really doesn't help us at all in understanding this urine test. One thing is true, that morphine is not metabolized to codeine. So the codeine there did not come from the metabolism of morphine, but it could have come from the impure nature of heroin if it's made from opium and it can contain codeine. So that was his. Now, that's really getting very virtuosic, the interpretation of that. I think it just alerts us to the fact that there can be limitations in quantitative testing, and want to be really careful about interpreting them, not condemning people as might easily happen here, and saying, well, now this person is condemned anyway because the 6 monoacetyl morphine shows they have used heroin. Where the codeine comes from could be a speculation. Some people, as you know, may consume codeine to try and conceal the source of morphine in their urine. So that's another little trick that our expert patients may play. The second immunoassay requiring further testing was for the amphetamine type substances, and duly showed both amphetamine and methylamphetamine. And there we've got some quantitation of the two. Does anybody think that it's useful to know the ratio of methylamphetamine to amphetamine? It's a rhetorical question. Some of us might look at that and try to work out how long ago the methylamphetamine was used and whether the person, what they actually took. But I think in the end, it's of little use at all. We know that methylamphetamine is converted to amphetamine in the body. So limited value in quantitative testing is my bottom line here. Now, here's another case where a person gave a urine test, and it was 6 days after their amphetamine use, which they confessed to, and it was still positive. The question was, in 2012, the question was asked, is this possible? And Peter Bowen said, well, we used to think, beg pardon, that amphetamines were only detected for 3 days after use. But by then he was saying up to 6 days, because methamphetamine is metabolized to amphetamine. So you've got 2 elimination half-lives, one after the other. The other reason was that methamphetamine now is so cheap and easy to manufacture that the doses that people are consuming are much, much higher than used to be the case for amphetamine hydrochloride. Just noting that the wisdom back then was that 6-monoacetyl morphine, that, as we know, the smoking gun for heroin use, can usually be detected only for 6 hours, maximum 24 hours after use. So if a person says, oh, I used 6 days ago or 5 days ago and it's got monoacetyl morphine, in those days you wouldn't have believed it. Similarly, cocaine, relatively limited duration, MDMA, limited too. But I'll come to caveats around that in next slides.
Oh, can I just interrupt, Richard?
Oh, yeah.
Just to highlight, we've probably only got about 10 minutes left.
Okay.
Maybe a couple of,
I've got 13.
Yeah,
okay.
yeah, that's pretty close. Yeah.
Just note this urine test. This is after a motor vehicle accident, which explains the person's in hospital, ketamine and the lidocaine. Whether the cocaine is actually lidocaine that's being misinterpreted in the testing, can't be sure. But here, for one of the first times, you see the miracle of heroin itself, diacetyl morphine, being found in urine tests, which until the last couple of years I had never seen in my career. Why are we now seeing that? The answer from the laboratory is now that their testing is so sensitive that they go down to such micromolar levels that they can detect traces, very, very tiny traces that they could never detect before. Now, that is the case if they are reporting below the reportable thresholds, and that's what some hospitals are doing. So that's just an interesting point there, and it could also explain why some people are finding it very difficult to get any kind of negative amphetamine assay, methylamphetamine assay, because that too is now detectable down to such low levels that if you're using more than once a week, you'll never have a negative test. Now, here's a poll question. This person who's on buprenorphine comes in with a negative test for buprenorphine in the urine. Are they diverting? Could they be substituting? Could the lab have failed to test properly? Could it be both 2 and 3? The audience votes for both 2 and 3. Warms my heart. Absolutely correct. Let's see if we can advance the slide. Okay, there's a paper by our colleagues at RPA on just how frequently buprenorphine is not showing up on routine drug testing. And the reason is that the parent compound buprenorphine is only renally excreted into the urine to a trivial degree. So you really have to look for its metabolite, norbuprenorphine, as well as knocking off the glucuronide by hydrolysis and so on. So many people, labs are knocking off they're performing the hydrolysis step, but if they're not testing for norbuprenorphine, they're not going to find it. And so accusing people of not taking their medication because their urine test is negative for buprenorphine, particularly when they're on a depot or they're having daily supervised sublingual treatment, is of course absurd. Just so that you can see the range of benzodiazepines. Now here's one on GCMS where temazepam has been identified, and the report identifies that they can't tell whether that has come from diazepam or oxazepam or temazepam because they're all converted between each other. So it would be speculative to know where that temazepam has come from, whether it's the parent compound or not. Okay, last question. The cannabis test is positive by the appropriate standard above the threshold. Which of the following is true? They've used cannabis in the last 24 hours. It's a smoking gun. They used in the last week. They used in the last month, or nobody can say. Great, the majority of people getting the right answer, nobody can say. Reason is that, like benzodiazepines, cannabis is lipid soluble. It sits in fat stores for a very long time, leaches out over a long time. So the test can remain positive for quite a long time after single use. Now I'll just move on because we have to get to Daniel's case.
All right, thank you. My last case for tonight. We've got Mr. E. He's a 23-year-old gentleman, no significant past medical history, has used recreationally cocaine and cannabis before. Presents to a clinic. He had a product sold to him or advertised to him as a cannabinoid e-cigarette. But when he uses it, he feels sedated, his breathing slows down a bit, and he has an unusual withdrawal syndrome as well. Sounds a bit suspicious. I guess my question is, how would you kind of respond to this presentation? So it's symptomatic management for cannabis withdrawal, referral on to a local drug health service for review, maybe just some further testing, blood, urine, maybe test the product itself, or not sure, but hopefully GCMS is involved. Give it a few seconds for that. Someone did make a comment, take home naloxone. I think they're catching on. And most of you want to organize further testing, and some not sure, but hopefully GCMS, and referring on to local drug health, always a good answer as well. Next slide, please. So this is a bit of a trick case and trick question. This patient was an inpatient at the time. The top left is his UDS immunoassay, which was positive for cannabinoids and cocaine, as we expected from the history. We were giving him diazepam in the form of agitation management, which showed up in his GCMS on the right as well. But we did further testing of his blood and urine and the e-cigarette liquid itself. At the top, as you can see, it came positive for something called protonidazine. Nidazines being a synthetic opioid, which are on the rise in Australia and around the world. It also came positive for potentially a metabolite of protonidazine and desethylprotonidazine as well, which was unusual because he was given what he thought was marijuana as well. If we move on to the next slide. Yeah, so this gentleman presented to a local withdrawal unit for withdrawal management from what was initially advertised as cannabis. We have a cluster of synthetic opioids in Sydney, which were essentially young people who were sold cannabis predominantly, sometimes nicotine, e-cigarettes as well. In this case and several others, blood and urine and direct substance testing was positive for protonitazine, being one of the main nitazines as well. Nitazines being an emerging threat around the world and in Australia as well. Most of our clients requiring inpatient management, and most, if not all, ending up being inducted to OTP. And move to the next slide. I will answer Brian's question in the next slide after this one. This is just one part of the story of the increasing role of the new psychoactive substances coming around. So synthetic opioids, nitazines, fentanylogs, for example. There's other synthetic cannabinoids, think caffeinones. There's a whole host of new hallucinogens and psychedelics coming around the world. And there's a new form of every modality of substance use you can think of as well. And if you move to the next slide, I'll answer Brian's last question. The whole point of this case is that the immunoassays and the GCMSs we have available, even in hospitals, they can't detect the majority of these substances. In New South Wales, we have the PRIZE program, which is basically it's a program basically where they can test all the newer substances coming out, or at least try and identify any unusual cases that you might come across in terms of the substances themselves, the presentation, or if someone is sold marijuana and they present with an opioid toxidrome, maybe we should test it with someone in particular. These would be the people to reach out to in terms of getting further investigations as well. The next slide. I think that's it. I think it's back to Dr. Hallinan.
Thanks for that, Daniel. Perhaps we might share the phone number to contact PRIZE later on, or put it in the chat, or the email address.
So did you? There's a question about do GPs have access to getting the products tested? Do you know?
Yeah, I see no reason why they can't talk to PRIZE as well. If you have a case, it's always worth a discussion with them. And I don't think I included the number, but perhaps we can at the end.
Yeah.
As well. Yeah.
Okay.
Yeah,
so basically recommend contacting through PRIZE or something.
Yeah.
Something like that. Yep. That pathway.
Absolutely.
Great. Thank you.
And some very brief lasting points. How you get information from patients is really important. I think urine tests are the beginning of a discussion. They're a stimulus to a discussion. And you can do it in various ways. Would you be happy to give me a urine sample today? And so, no problem, doc. Well, then maybe you don't even need it. Or you might just say, if you did a urine test today, what would it show? And they say, oh, well, I'm going to tell you it'll show ice. And again, you might even spare them the urine test. Or you might go ahead and say, oh, well, let's get it because there might be something else here that's even worse. But, it's a bit different from the kind of strict and military view of how urine tests might be used. I even ask people to come in on a day that suits them to give us a clear urine test to demonstrate a degree of continence if they have it. So if a person says, like, you're only here on Thursdays and Fridays, and I always use on payday, which is Wednesday, and so you always get me for the wretched amphetamines. So, okay, well, how about you come in on Tuesday? Here's some forms, and some of the nurses were a bit uncomfortable with that, but I find all these different approaches can be useful. It's if a person is coming up with, if you even send a person home to bring in a urine test because they've got performance anxiety, you might think that's got no validity at all, but I've done it sometimes because eventually, if they're mucking around, you'll catch on to it. Now, those things are a little bit left field for you, but remember also that takeaways have got benefits as well as harms, and so refusing takeaways has benefits as well as harms. Finally, it almost shouldn't need saying, but never accuse a patient of lying on the basis of a urine test. I once heard a prescriber say to a patient, "You're lying," in response to their urine test. And the patient was later in tears and explained to me that they weren't lying at all. And, it's obviously not really helpful or productive, is it? That's all I wanted to say. And so
could I just
Yep.
One more question in the chat before we wrap up. Terry asks, do blood or urine tests differ if cannabis is smoked or eaten?
Fundamentally, no. It would be just a matter of the quantity. Now, I'm not sure of the bioavailability of oral cannabis. I should know that. But its bioavailability, smoked is obviously pretty high too, and so I don't think you could distinguish between them by blood or urine tests.
Thank you.
Great. Thank you all for joining us this evening. We hope you found this session helpful and informative. A big thank you to our speakers, Dr. Richard Hallinan and Dr. Daniel Dutkiewicz, for their excellent presentation, and to Dr. Sharon Reed for helping manage the chat and discussion. The presentation slides will be available shortly on the OTAC website, and you can also watch recordings of previous webinars on the OTAC webinars page. If you have any suggestion for future topics or clinical cases you would like us to cover, please feel free to email us at the OTAC mailbox. Our next webinar will be on Monday, August 19 at 6 p.m. with Dr. Chris Sermonti presenting on the impact of opioids on the endocrine system. We look forward to your attendance. Thanks again and have a great night.
Thanks.